Good afternoon. This is a very important subject of clinical governance called risk management, and I would now like to discuss its application and requirements for it to be followed under the NHS primary care. So, if we look at this slide, we'll readily understand that there are a large number of things which have come to light as a result of misdemeanors on the part of many doctors. It has become a rule of necessity, but it appears to impart significant good to the patient care as well. In the past, I've had experience of working for Medical Practitioner Tribunal Service, the GMC, the Ombudsman, the CQC, and the courts and the tribunals, having been a vascular surgeon for a large part of my life. So, if you look at some of these examples, you will see how we can apply risk management in our modern practice. We will come back to it to categorize it into a form of diagnosis that we can understand, which could be used for learning. So, this is a young girl who had inherited a large sum of money, but was finding it insufficient to be able to purchase a property of her own. And in frustration and with no friends to turn to, she came into a colleague of mine and asked for something to be given to her by way of a prescription so she could painlessly die. She also said that if nothing was done, that she would jump in front of a bus and in her paperwork, the neglecting doctor would be responsible. My colleague took my advice and contacted the casualty, mental health team, crisis intervention team, and tried to make contact with the patient herself, and she did not reply. A month later, she came in and saw a trainee and asked for a DNAR form to be completed, which he declined with abundant reasons. And then we took it upon ourselves to contact the consultant psychiatrist, having failed to attract attention from the crisis intervention team. And we were told that she had capacity and therefore they had to respect her wishes. However, this is a scenario where she had expressed thoughts of suicide and had also shown the way that she would undertake to kill herself. Another example is of a 3-year-old child who had come in with a, two other siblings and the mother. And she said that she thought the child had ADHD and was therefore constantly upsetting the family and that he was throwing a tantrum and that at times um, his biological father would turn up and discipline him in some ways and he would calm down momentarily. The mother thought that that her child this child had ADHD, similar to the ADHD of the older child, and she also described some features possibly of seizure. Anyway, we dealt with this case appropriately and made the appropriate referrals, gave her advice, and also told her, gave her some safety net advice as well. And if you look at this example, here a patient who probably thought he had chronic fatigue syndrome or fibromyalgia was finding it not possible to work, and that he had been referred already to rheumatologists and numerous other specialists and had undergone various investigations. And this is what he said. Having been to the specialist, they cannot find anything wrong. Can you give me a 3-month sick note? So he didn't want to work. And that he also said that he was in need of being he requested issuing of a blue badge with the GP support. Further example, this concerns a lady who had sort of, the power of attorney, lasting power of attorney, in conjunction with her brother for her mother, who she thought was not behaving normally, and that she declined to give pocket money to the son, and that was threatening to expel both her children from the house. And she felt that there was abundant justification for sending her to the nursing home, which would allow the brother and the sister to possess the house. So, this is a legal example concerning capacity or lack of it. Lastly, it was a personal encounter with a lady who had come in at around 5 o'clock, insisting on being prescribed methotrexate. And she said that this would be her 11th injection and that she had been trained to inject subcutaneously, and that the prescriptions were dispensed at the hospital pharmacy. But that on one occasion, the hospital pharmacy was shut, and so the consultant had given him an outside prescription. But that she was quite sure that the injection she required was methotrexate 200 milligram in 40 mils. A 4-month-old letter confirmed the diagnosis of rheumatoid arthritis, and had also said that the consultant would like the patient to remain for the time being, on 20 milligram methotrexate. And there was a protocol of folic acid as well. I reasoned with her several times, explaining that in my knowledge and experience, the dose and the volume that she described were not compatible with safety or with subcutaneous injection. He insisted until I asked her to wait, and I attempted to contact the duty rheumatologist or duty physician to no avail. Then I sent a receptionist over to the community pharmacist where she had had her hospital prescription dispensed on one occasion. They sent in a label of dispensing, confirming that they had dispensed her with 20 milligram methotrexate in zero point 0.4 ml solution. I mentioned it to her and gave her an appropriate prescription, and she remained unhappy but went away. There were no apologies or thanks. So, what have these misdemeanors been which have resulted in development of risk management? Harold Shipman had the gift of the gab, and he charmed his patients, elderly patients that he did home visits on, and eventually, with prolonged contact, they would put him down in their will to possess their property. He issued a large number of death certificates, and it was held that he also occasionally injected the lethal dose of some medication. When he was sentenced to 16 years of imprisonment for homicide, murder, and other related crimes, within a couple of years he committed suicide in his prison cell. Dr. Green assaulted male patients. Ailing assaulted female patients. And there was a rising number of GMC complaints and complaints to the courts through the solicitors for clinical negligence. And on top of that, news media got hold of such misdemeanors. And following the matter with the Bristol Royal Infirmary, The case was handed over by the government to Professor Kennedy to make a full investigation into the um, matter, as well as suggestions from this learning. Bristol Royal Infirmary had employed four consultant pediatric cardiologists, and an anesthetist discovered that there was a very high post-operative mortality rate of children. He reported to the medical director, then to the GMC, and finally, through him, information came out that 34 deaths had taken place in a short space of time post-operatively in children. And it appeared that on investigations, Professor Kennedy found that three of the doctors did not engage with skill learning, skill update, or with knowledge gain activities, and they were eventually sacked. He also found broadly that at that time the NHS had a club culture, a blame culture, a scapegoating culture, and that it did not insist on the doctors undertaking activities such as CPDs, quality improvement activities. And as a result of his recommendations, which said that doctors in practice did not care much about the patient feedback, and this had brought in significant harm to the image of the profession, as well as was a matter of considerable risk. The NHS then developed a tool called clinical governance, which allowed all of the NHS organizations, primary and secondary and others, to remain accountable, to continuously improve their standards, and visibly show a continuing good quality of their care service. It also talked about safeguarding, maintaining standards, and professional environment in which clinical activity could flourish. While this had come into being, the conditional fee arrangement authorized by the courts had continued to increase the negligence cases, and these are no win, no pay cases. So the appraisal and revalidation came into being, and they had the highlights of risk management as the first priority, followed by continued education that peers could accept, skill training, how to impart information to patients and to others, what were the rules of information commissioners, and that they would themselves each year audit their performance, and this would be overseen by an appointed and trained appraiser. This would be to see if the clinical practice had conformed to the GMC good medical practice guidance, as well as there was evidence of evidence-based medical practice. A significant importance was given to collecting feedback from the patients as to how they perceived their doctor to be. There was a need to appoint sufficient number of support officers, medical officers, nurses, and so on and so forth, who would act as employers as well as um, they will underpin their activities under the health and safety at work principles. So now we should talk about what risk is. A risk in healthcare is an adverse event which had caused a harm in the past, continues to cause harm now, and will have the potential to continue to harm in the future as well. And the harm is an unwarranted, unwanted, undesirable result of an adverse event which had caused suffering to the patient. So, if one knows about risks causing errors, then how does it affect patients? It would cause physical damage of the health, such as a patient being given an antibiotic to which he is allergic would suffer from anaphylaxis and more complex disorders. A patient who had a mental illness, if not seen, could either cause harm to themselves or to the community at large, and suffering from a harm that was not expected physically would lead to mental anguish. Activities of reduced patient care or lack of following guidelines would lower the image of the medical profession and could cause public health problem, as we often saw in the COVID years. Please remember that you cannot prevent a risk if you don't know what it is. So the risk management is the strategy which identifies risks, whether they had been caused in the recent past, in the past, currently, or will cause a harm in the future. And it's a new duty which involves all members of the team. So if there is a chain, then there is no separate duty for one or two. And so each member will have their own duties to perform with risk management. If a risk or an error is identified, it should be reported to those who can put a stop to it or learn from it, and such errors or risk should be documented. The harm should be controlled immediately and it should be prevented for the future. Enough learning should be had with discussions to alter protocols and policies, and then to share the knowledge with others so that each person knows the relevant aspect of risk management in their appointment. So, the philosophy is that if you do not know what risk is, how will you be able to prevent it? So, whilst following the Bristol Royal Infirmary inquiry, I became a medical lawyer, and as my specialty, I chose clinical risk management as well as clinical negligence. And so I found that the core principles of risk management are these: identify, analyze, control the risk, and cost it. Remember that if you don't know what an event is by way of, or if you don't know if an event is an adverse event and it's a risk, how would you be able to prevent it? So identifying risks mean that you would categorize risks either as significant event analysis or learning event analysis. Before 4 years, everything which had a risk potential used to be categorized as significant event analysis. At that time, the GMC sought fit to describe what an adverse event uh, is to be called as significant event. So the threshold of life, that means if an event led to someone's death, or if someone had a deteriorated condition as a result of an adverse um, treatment or handling, and that he nearly died, it would be called significant event. And so the result was a large number of doctors, when they were undertaking their annual appraisals, they would tick the box saying that they were not named in a significant event. And that would be the end of risk management. Some of us rebels at the GMC voiced an opinion that this would lose a considerable volume of learning from risk managements, particularly if the threshold was less than significant event, according to the GMC. So that if a doctor prescribes amoxicillin to a John Smith that the nurse had booked and then sent the notes over to the doctor by computers, unless the doctor makes sure that the correct John Smith with his address, with his ID, is what he intends to prescribe, he'll be making an error. And so it's possible that the person before him would be prescribed wrongly. So checking of ID through various means became important and essential. Sometimes a risk may appear to be in the making. So a nurse walks in asking a doctor that this patient with ambulant blood pressure is still not under the accepted threshold, has been on ACE inhibitor ramipril at full dose of 10 milligram. So how about adding something else on? And the doctor asked her what she thought. And she said, oh, he's elderly, so how about diuretic, benroflumetazide? They both looked at the medical background of this patient and discovered that not so long ago he had hyperuricemia causing him gout. So benroflumetazide, if given, would have caused him gout, hyperuricemia, and other problems. So therefore, this near miss was a potential risk, and eventually the compromise was that an additional antihypertensive such as calcium channel blocker will probably be better. The near miss has came into being from the British Overseas Airways Corporation airline pilots. They were the pioneers of risk management. There were very many kinds of risks that they identified, and one of these was that planes should fly in individual airspace. That means if a vertical height of, say, 10,000 feet was allowed to a particular aircraft as he was ascending, going to a faraway destination, and the pilot, through his scanners or through his vision, saw another plane coming in his direction at about the same height, he would take evasive actions, and then, of course, the fatality or aircraft accident would be prevented. So they gave it a term of air prox. That is, two aircrafts were in near proximity, but the matter was handled well and a disaster was averted. A similar example would be when it is decided on a ward round that a patient would have 2 units of blood transfusion for an indicated condition. The pathology would deliver the bottles one at a time to the ward. The nurse would receive it, will prepare grounds for this infusion, call in another nurse, and they will independently check and communicate with the patient as well that this is his name, this is his date of birth, this is his address, and this is his blood group. So two people checking and then Counter checking with the patient would reduce hazards. I've already mentioned about the example of hypertension. So, by acting judiciously and promptly, you could avert a risk or a harm, and this would be a near miss. Another form of risk is organizational failure. And I'd like to read from what I had already submitted as a handout. This relates to root causes. Short staffed surgery due to several people on holidays together, computers not working, new manager attending meeting with an accountant, few doctors on premises, and the receptionist forgets to pass on an important message to the duty doctor, and the patient could come to harm. So, whose fault is it? This is clearly an organizational failure. That safe surgery, safe appointment system cannot be carried out without at least a minimum backup facilities, and each member should know what they need to do. Even breaking of one link would damage the entire chain. Sometimes an action that you take to avert a disaster would be early enough and it will act as a good deed. Good deeds are often followed more energetically than significant events. So, having identified what risks are, then we should analyze it. So, when you analyze, you categorize risks as significant event analysis of risks which have the threshold of loss of life or thereabouts. And less than that threshold would be learning event analysis. So we will go back and look at a significant event analysis and a learning event analysis from our first and second examples. So this lady had thoughts of suicide, had made a plan to commit suicide, and was searching out and seeking analgesia or something that she could painlessly die with. And of course, she came back thinking that if she were to jump in front of a bus, they will, if she survives the accident, they will resuscitate her, which she didn't want. So she had asked for a do not attempt resuscitation form to be completed by two doctors. On inquiry, it appeared that the consultant psychiatrist, his team, crisis intervention team, liaison psychiatry, they all said they had tried to contact her, and in the initial contact, they discovered that she has capacity. That means she, being an adult, which is over the age of 16, could choose to decide whatever, as long as it was not a criminal activity and it did not harm someone else and it did not harm the community. So they were powerless. They could simply send social workers, arrange numerous continuing talking therapies, CBTs, but they could not section her. Patients who do not have capacity or have distorted version of capacity can be sectioned under the Mental Health Act 1983. This was an example of significant event and we looked through it, we discussed it, we made provisions of following this lady up, even if she did not respond to our phone calls or to our letters or appointments. Significant event analysis. Looking at this, the mother was seeking a diagnosis of ADHD declined the doctor to have to conduct any examination, physical or mental, and was just keen to say that, oh, well, he has ADHD, and that we need to do something so he calms down. So she was searching for calming medication. And here was a condition where we would necessarily need to think of the child's best interest as well. And so, therefore, it was an example of learning event. So, similar to significant event are critical incident reports when somebody dies in the hospital, sentinel event where one cause leads to fatality of one patient. So the advantage of learning from these is to be able to prevent such happenings in the future. And so when an adverse event arises and you find it categorized as significant event or learning event, so remember that significant event should be reported or discussed immediately, learning event very soon, and both should be put into a risk register, which is an electronic register. Eventually, significant events all find their way to NHS litigation authority, and learning events are collectively looked at by NHS England and the risk managers. And so they choose some and pass these on nationally. The third part of the core aspects of risk management was controlling, controlling or acting on risks. The idea is if harm has taken place, one should minimize it, treat it, control it, then to prevent it, and then, of course, to report it as well. So there are numerous ways in which we could deal with this. So, how do you control this aspect? That a frustrated lady comes up to the reception to say, I've been waiting for some 20 minutes. I'm sitting next to a gentleman who is scratching himself and he spoke on the phone to someone saying she's got shingles. He's got shingles. And I'm pregnant and pregnant by 5 months. Should I be sitting next to someone suffering from shingles? The receptionist was taken aback, immediately called out her supervisor. They both decided that she must be moved away completely, and that there was a question of then checking to see if she has antibodies against herpes zoster, because shingles in pregnancy can cause catastrophic disabilities in the fetus. Another example, a mother comes in who had just put her 2-year-old child in a playpen, and she was accompanied by somebody else as well. The child was playing in that playpen, and somebody came in with a dog, sat down, released the dog, and the dog simply went up to the playpen and was licking at the soft toys. And the mother complained, saying that I don't want my child to be touching the dog licked soft toys. It is unhygienic. It appeared that the patient who owned the dog was blind, and this was a guide dog. So apologies were made to the mother, and of course, the solution was to get the dog back again and to link it up so that the blind gentleman could keep a hold of the dog and not allow it to wander. So one should control it. And of course, the next thing would be costing it. So, how does one cost the action of control? So, the answer would definitely not be moving the surgery into larger premises where there would be sections of um, patients who needed privacy and patients who had special needs. It would be too uneconomical. So the costing part of it should be practical and it should be affordable, and it is something which should be done as a matter of convenience, economy permitted. So when a risk is noted, it should be logged. We have also mentioned about significant event and learning event. The data should not be released without due process, as has been advised by the Information Commissioner. Actions emanating from the discussions of significant events or learning events should be put into a meeting, and the practice protocol and the policy should be altered accordingly. And then it should be shared with the rest of the team. So remember what I had mentioned and I had found in my thesis. The four principles of risk management were to identify, to analyze, to control, and to cost. And you won't be able to stop a risk if you did not know what risk is. So, with so much being found out about risk management, why are there still barriers to the practice of risk management in the NHS? So, we have a forgiving practice. So, a nurse comes in and says, well, look, I need some advice from the doctor, and the doctor is always coming in late in the morning. My first two patients would be kept waiting until I would get sanction from the doctor. I've had chance to discuss with it, becoming a regular process. The senior partner would say, you're talking about Dr. Smith. He's a senior doctor. He's a brilliant person. We've not seen any complaints against him for quite some time. It's not like him. There must be a simple reason why he's been arriving late in the last few days. Maybe it's a car problem or domestic issues. I'll have a word. I'm sure it'll be all right soon. So, lateness should not be condoned through forgiving. One should find out the specific reason and sort that out. The second barrier would be ignoring the root causes. And I have already mentioned in this the handout number 14, and that is surgery was short staffed due to several people on holidays together. They should not be on holidays together. Computers not working. This would paralyze the activity of the surgery, and that shouldn't be allowed go on any length of time at all. New manager who doesn't know the ropes, she doesn't know all of the staff, is having an important business meeting with the accountant. She cannot be distracted or disturbed. But the most important thing in a medical practice is patient care. And so, therefore, if it appears that a harm has taken place because of all these delays, then until you eradicate each aspect, each little things, each little thing which had contributed to a collective harm, unless each item is sorted out, it will not improve. So this led to root cause analysis. Other barriers are scapegoating. So I've mentioned item 15, which is Immediate blame of the faulty person so others are vindicated. Paula is the manager. She blames Dr. Babar for not checking visit books, so therefore he did not undertake a visit on that particular day. And he says it is the manager's fault. Traditionally, the manager puts down on the visit screen as to what visit is needed and who would be doing it, and that she did not do that. And so he did not know that a visit had been interposed without his knowledge. She said that the first thing she did when she joined the surgery was to have a meeting with the staff and said, well, if there's anything important, I should be told immediately. And so they both thought that the junior receptionist should have knocked at the door of the manager, passed this message on. She should not have waited. And so they said, well, look, she's young, still under her probation, and probably working in the medical practice is not a good job for her. If we now retrain her, I believe that the manager believed that there were already some problems with her in the past, which records showed. So it would be far more easy to sack her and employ someone else rather than to retrain her. That's scapegoating. It was actually the manager's fault. Blame culture. And so the blame culture is about the same, that you find someone to blame, not investigate the root causes, and the matter is resolved. Paternalism. The manager would say, who had been in practice for a long time, that, these things do not happen. If the doctor did not look at his tasks regularly, it's not like him. There must be a reason. We must check it up. He's a senior person, so let's just leave it. I'll have a word with him. Poor communication. So unless you communicate with a person having noticed an error who is in a position to control the risk, your communication is poor. So it is inherent with all primary care units to not admit faults. They find others to blame. So these are the barriers of risk management. So the risk management would be what happened. Look at this scenario. A businessman comes in the evening, in the out of hours, has an urgent appointment, saying it could not wait because he would be flying the following day to Japan for an important business meeting, which would help the community. He spoke to the doctor privately, saying that he had been involved with somebody that he was unaware of their health status in respect of sexually transmitted illness. And although he doesn't have any real symptoms, he feels um, at the end of his meeting with the other person that he must be protected against possible sexually transmitted illness. The doctor immediately took some more details and said, well, look, you need to attend sexual health clinic, and it's usually available until 7 or 8 in the evening. It's a walk-in service. They take your history immediately. There's no waiting time. You just go in, and as soon as doctor is available, he'd see you. And they do cultures, swabs, even blood tests. And then when they've made a diagnosis, they give you appropriate treatment which is reliable. They also tell you what length of time you would need to take the treatment for. And at the end, they would look at the source and do some contact tracing. I'm a family physician. And he somehow persuaded him, saying that, look, I haven't got time. My flight leaves at 8 o'clock in the morning. To reach Heathrow Airport, I would have to leave home at about 6. There isn't really any time. So, which is the commonest sexually transmitted illness in this region? He said it could be anything. You can't just simply say that chlamydia is the main reason, but some people would have chlamydia and gonococcal disease or something else. He said, well, look, if I were to ask you to prescribe something so that I could at least not develop it any further, he declined at first, but in the end, for some reason, he was persuaded into prescribing a fluoroquinoline, that is ciprofloxacin, saying that it would be okay for chlamydia and possibly for some other sexually transmitted illness, but I'm reluctantly prescribing it. And he put that down in his notes. He gave a prescription, which obviously he had dispensed from an emergency chemist. This is what had happened. So, what could have happened? He should have insisted that he is bound by guidelines. He has the care of contact, spreading the STI as much as the patient himself spreading it if he has STI, and that there is no alternative but to seek walk in urgent opinion from the STI clinic at the available hour, which would be tomorrow. He should have done this, and it could have led to control of the contact, the patient, all will be well. So, what actually then happened? Patient took one tablet, developed during the air flight, he developed tendinitis in various tendons, as he described. He reached Japan, found himself unable to travel back, and he developed profuse tendinitis, eventually involving the Achilles tendon, and he was unable to walk. He was privately treated for tendinitis, and it is not clear whether he was treated for any STI or whether he had STI. So the lessons which were learned was 6 months after the initial event, a solicitor wrote a letter saying that just with one dose of ciprofloxacin, he developed profound tendinitis. He became totally unable to function, and it took him 3 months of rehab, which he is now currently completing in the last 3 months here in the UK. His business was ruined, his trip was ruined, and therefore there was a litigation. The cause was established to be unwarranted ciprofloxacin given for STI causing tendinitis, particularly Achilles tendinitis. This was discussed thoroughly. I was invited to attend, and the joint view was that it was a doctor's discussion which led to this problem. Patients can induce doctors to want something that suits them. The doctor should be always guided by the principles of good medical practice, which is safe prescribing, appropriate prescribing, and dealing with the patients correctly. So the matter is ongoing, but the doctor was then suspended. So this is what happens when you follow up significant event. In learning event analysis, you come up with a suggestion, you see if it has worked, you then reflect on it as to whether there is something else which could be added to make it even better, and then make necessary changes and discuss it. And so we need to work out as to whether the change is working through an audit. The lessons learned from risk management is you should identify quickly, you should have practical controlling strategies, and that you should then keep up to date and spread the knowledge. When a trainee joins a practice, or if locums are employed for a short period on the ward or in the primary care, then they should have appropriate induction as to where the emergency drug box is, where the defibrillator is kept, where the nurse is available, and the room environment, and how to call patients over. So these things are aspects which would control many aspects of risks. So now let's look at why management of risk is difficult. It requires vigilance. Almost immediately, you should do something. You should act on the basis of common sense. Common sense is that modality of innate quality which is difficult to teach. You learn it from experience, modeling, from speaking to a mentor, seeing others produce a good job, and that you develop common sense in relation to specific tasks and specific problems. It is everybody's responsibility because doctors do their annual appraisals. It is their responsibility. It's also the responsibility of nurses and the manager undertaking the receptionist's appraisals. Some people would say if you look at events critically, you are spending too much time, and therefore timeliness would be lost. You'll not be seeing your patients every 10 minutes. It would take much longer. You'll run late. It requires a lot of paperwork. And also, sometimes members of the team say that it's not their problem. Say a locum doctor would say he's only there for a day. He's not going to come back for a meeting, even if as a result of his activities somebody has come to any harm. Then again, if lateness is reported by a junior receptionist for a senior doctor, because he is an employer and a chief employer, he would ask the manager who reported it. And they say it's a junior receptionist. So there would be discipline. You should report a risk management activity to a person in a position to challenge and to control it. So you're always looking for a senior person. Paternalistic attitude, such as if you ignore it and forget it, it's such a rare thing, it won't happen again. The matter will be forgotten. So, why is general practice itself difficult? GPs go to same or similar medical school, read the same books, follow the same guidelines, but it is common observation that there is little uniformity. What one GP does for a scenario, others will do it differently or do other management altogether. If the patient's list is too large, you wouldn't be able to manage safely. In the NHS constitution, reference is made that If a GP has 1,200 patients, then there should be one full-time doctor for their care. So imagine 12,000 patients. You would need 12 doctors, literally full-time, and there aren't as many. And so you have bridging gaps from nurse practitioners, paramedics, physiotherapists, and doctors in different titles, research doctors, trainees, supporting the doctors. Now, how are doctors paid? So, we are talking about a partner. The partners are paid by the NHS quarterly or thereabouts, and they are paid according to the head count. So, the capitation fee is for one registered patient who goes through registration, new patient check, has his blood pressure taken, biometrics recorded, the NHS would pay him £164 per year. And for day-to-day care, patients would cost, each patient would cost 31p. And the representative committee is currently negotiating for a rise in that amount of money from 31 to 42p. The primary care doctors are accountable to intercalated boards, clinical commissioning groups, NHS England, Air Quality Commission, and they are also accountable to admins services for health and safety at work. They are constantly worried about complaints to the GMC, litigation by solicitors for clinical negligence. The partners also bear employer responsibilities, so they could be taken to the employment tribunal with a significant loss of income of the surgery. So doctors are responsible for training of their staff, such as chaperoning, communication, infectious diseases control, putting up various posters, having information given through the TV screen. And they are supposed to have annual appraisal. And in the annual appraisal, they must show within 5 years patients' feedback, colleagues' feedback, whether they have received complaints, how much knowledge gain they have made, and they're supposed to have 50 credit hours of CPD. They need to have quality improvement activities such as case reviews, audit, uncertainties, and research and training. And so there are many activities which need to be covered in general practice. Managing reputation is important. Reputation of the surgery, management of the image of the profession. Some doctors feel that they're exhausted because of too much admin work and too little clinical work. Clinical work brings them pleasure and a sense of fulfillment, not admin work. They have appraisal worries. So, away from the family, they would attend weekend meetings for their appraisals. They will have various kinds of online learning as well in the evenings when they would rather spend that time with the family. So, this is why general practice is difficult in the UK. So, why is it popular? In this line of work, there is considerable professional motivation and there is privilege of distinction. Walking on the high street, going to a restaurant, being recognized as a doctor gives you a sense of distinction. People acknowledge you. In the UK, you, as a doctor, belong to grade 1 earner. The only other group that comes with you is lawyers. So doctors and lawyers have grade 1 income. Grade 5 is someone who does part time as a student work or minimum work. If you own something like a practice as a partner, you begin to like it after some time. Sorry. There is no age limit for the GPs, for the primary care physicians. In the old days, when a doctor became 70, he would be taken off the performance list. Not anymore. Some doctors cannot commit themselves to full time work, they do part time work, occasional work. So the revalidation system has set the minimum of 40 sessions per year being the minimum so that you could remain on the performance list. But if you are doing something important like you are a military doctor or working abroad for UK for some special assignments, then you could claim low volume work, in which case you could be doing substantially less and that your requirements would be reduced and you would continue to be on the performers list. If you have a good staff and a good practice manager, life becomes easier. Some doctors form a company with their spouses. So there are two directors, the doctor and his wife. They have a company. The company arranges for the doctor to go and work at the out of hours. And so this is like a company employing a doctor. So there are privileges of sharing expenses with utility, water, heat, electricity at home when you do partial work for the NHS as well. If you have a specialty, you could do some private work as well. And this is an extra income. Also, if you yourself feel that your performance is reducing, your knowledge has diminished, that you can't remember things properly, then you have detected an early burnout, and that's when you announce your retirement. And so these are the reasons why practice is popular. So I will not go through individual items relating to this heading, but I'll simply highlight one or two. So the four principles of risk management being identify, analyze, control, and cost. So imagine I will only discuss this one aspect, but not anymore. Surgery opens at 8 o'clock. Patient system starts working at 8 o'clock. Patients start ringing up immediately. And then there is a queue in the telephone system. And someone ringing up at 1 minute or 2 minutes past 8 will get a message saying, you are the third on the line and you will get in touch with the receptionist soon. Some surgeries say the waiting time is approximately 10 minutes. So if someone rings up a few minutes later, the receptionist is in touch with the patient eventually when his number has come up at 20 past 8. So he would say, I'd like to have a same day appointment with the doctor today. And the receptionist would say, sorry, sir, we had 12 appointments and they are all gone now. Can I help you to book time to see the doctor on another day? And there are all sorts of issues after that. Appointments could be telephone appointments, internet appointments, they could be face to face as well. So, all sorts of issues start off. A national audit tells us that the primary reason patients wanted an appointment with a primary care was to see a doctor face to face. This is still the same, although now A fair number of patients say, we'd like to speak to a doctor on the phone or face to face. This is the um, matter since the COVID years. Then there would be some who would say, I had booked a telephone consultation with your doctor, Dr. So and so, and he was supposed to give me a ring um, in the late morning. So I've waited all morning now and nobody has called. The receptionist would say, I'm sorry, we did tell you that we can't force a doctor to give you a ring at a particular time. He has other duties like patients in the primary care to see or to make his own phone calls or to talk to um, sort of hospital doctors. He will call you if there's a booked appointment. Then at about 3 o'clock, the patient rings back again and says, yes, I had to go out for an urgent 10 minutes matter. When I came back, there was an answer phone message that the doctor had called at 2:30 and said that if you still need an appointment or advice, contact the reception. So that call was wasted. Can I speak to the doctor now? Sorry, he is busy. He did spend time looking at your notes and then making that phone call, but he couldn't get in touch with you. Now I will have to rebook the call, and sorry, there is no further time for booking a telephone consultation for today. I can book a telephone consultation for you in 3 days' time because it's an advance booking. So it happens with missed calls. And the most difficult ones are requests for home visits. And of course, patients would say and give all sorts of reasons, such as I have no car, I can't walk this distance, public transport is not easy for me, I don't have enough money for taxis. If I take a taxi, would you pay for both ways? And so obviously the surgery is not able to do so because if they promise to pay, they become responsible from the point of view of any uh, travel illness, accidents, and so on. Then there's a matter of confidentiality. Um, Patients speak privately, and since the COVID, there's a step back distance which they must keep. But some people speak loudly. And so if someone is loudly discussing their conditions or reasons for seeking an appointment, they feel embarrassed. Then they say, well, can I speak to you somewhere else? And there's always provision for the receptionist to take the patient to a different place so where others cannot overhear their conversation and deal with it. But during that time, that receptionist will not be able to attend her telephone urgently if there is a need. So there are all kinds of issues in the reception, who to prioritize, and then of course waiting room issues. So I will not go through the other aspects because you are experienced and you will understand it yourself. So when the hospital letters arrive, should they be not in the correct patient's notes? Should they be seen urgently or routinely? If the reports are lost, what happens then? If an activity is requested by the hospital, such as change the dose to this from that, then they need to be looked into. Documentation is also the same. So if a receptionist says that this patient has been seen by the nurse for her combined oral contraceptive pills and she had found her observations to be good and nice and the patient is aware of possible complications, doctor, can you please issue a 6 months supply? The doctor would probably issue a 6 months supply and then send back the message to say it's been done or not done for such and such reasons. We have briefly mentioned about data confidentiality, updating, and we must remember that after a patient's death, the patient's notes belong to the Secretary of State and they must be preserved for so many years under the law. Interpersonal relationship needs to improve. All doctors must meet with all receptionists and admin staff from time to time so they could understand how the process of output can be improved further. Of course, these are things which doctors do anyway. Some use Pendleton, some use Cambridge Calgary method of consultation. They run on time. And if they need a chaperone, then it's predetermined, and use of chaperone or interpreter will require additional time. And this would have been managed as a double appointment to begin with. There are still some heart sink patients. Grove has written a book on heart sink patients. I'll just give you an example. Doctor, you know that I suffer from tummy pains. I've had MRI scans, endoscopies of various kinds. The hospitals have done numerous special blood tests and they've not been able to find a cause. So, you know, doctor, that I'm totally unable to give up smoking. So, where do we go from here? What does the poor doctor do other than saying that you need to be attending CBT, cognitive behavior therapy, and this will help in downgrading your cigarette smoking, and even vaping has its risks. So these are issues that confront us every day. And if it's a teaching practice, we must oversee our trainees and then have advice on debrief. Some trainees over investigate, go on fishing expedition. So they should be within their boundaries, should not repeat what has been done by another doctor in the recent past. There should always be a management plan. Prescribing has a special consideration that you must be within your boundary. You must make sure you supply an adequate quantity and that the patient isn't stocking up. So compliance and concordance are checked. Clinical review is marked that having supplied a 2 monthly supply of antihypertensives, the matter will be reviewed in 6 months' time. So therefore, medication review would be in 6 months' time. So follow-up has similar ritual. Teaching of risk management is important. With regard to chaperones, they should have seen the procedure, they should have been trained themselves, they should stay within the screen, and they must only leave the room when the patient has left. The four principles are identify, analyze, control, and cost. Thank you very much. It's a lengthy presentation, and I hope you have found some use of it in your own practice. Thank you very much.